Welcome again. My name is Felipe Urdaneta, as I told you, and you will be seeing a lot of each other when you especially come to the VA. So, we continue with this lecture series, and I want to speak about perhaps the most important subject that we can talk about, and it's about airway management guidelines. The way I think about them is basically imagine you are in the middle of a storm in an ocean and you are have to get out of there alive. Of course, you and your patient, of course. You and your crew for that matter if you're in a ship. And therefore, we need to learn from mistakes that others have made so we do not make the same mistakes. And we also have to learn from very smart people that have come up with basically strategic plans as to how to avoid the potential pitfalls of encountering a difficult airway. This is such an important subject, and it's so important that I've divided it in two halves. This first half is going to be the basic speaking of them, kind of get you acclimated to them, kind of get you familiar with the guidelines themselves and with the algorithm approach that the ASA has recommended. And then the other one will do a little bit further deep dive into kind of things that are, I think, there are shortcomings of the current method that we have. Obviously, you're hearing my opinion entirely. There's a lot of more potential sources that can tell you differently. I'm just going to give you my 2 cents on the subject. As always, remember that what I recommend is for you to do is to take a look at this QR code that I'm giving you, look at the recommended reading, perhaps do some downloading of these articles. Obviously, they're all in the UF library. You can do it online, of course. And I recommend you start developing your own library itself, and you can start reading about what I'm about to say, and pause me if you need to, and continue then looking at the lecture, and you can see that what I'm talking about hopefully will make more sense. This is us. Some family basically entrust us with the care of their loved one, and patients don't come usually to have their airway taken care of. They come for something else, but in the process of that something else, the airway needs to be taken care of. And sometimes we have not done things adequately. Sometimes they're too difficult to be dealt with. But the bottom line is, at the end of the day, we need to return that loved one to the family that's entrusted us to take care of them. And that can be a baby, that can be a mom, that can be a grandma, you name it. This is us. And a little known secret is that this impulse of knowing about closed claims analysis and airway management started in 1980s when there was kind of push to figure out where were our shortcomings and where we're basically short in terms of successes and where we could actually do better. And turns out that in 1980s and specifically 1993, about a third of the anesthesia mishaps happened to be respiratory in nature, and 85% happened to be neurological damage during airway management. So that's what prompted the generation of the creation, the task force that created the first airway management guidelines that were published in 1993. So since 1993, we've had this beacon of light that happens to be the guidelines, and they've made so much difference. I cannot tell you, for anybody that practiced earlier than 1993, cannot tell you how things were so tough and things you got lost very easily without basically the guiding principles of the airway management guidelines. What I want you to think about is when we're facing a patient, there's a bunch of things. It's like a maze, and we need to basically know which parameters to choose, which are the potential pitfalls, which are the areas that are difficult, so that perhaps we can negotiate things adequately. In terms of that, I want you to think about of the guidelines as strategy. It's just a strategic plan. And if you think about it that way, then it will make sense of what you're looking at. Currently, and this is perhaps a little bit not exact, but this is basically as exact as it comes. there are approximately 9 official guidelines around the world and about 30 different algorithms. So, by definition, that means that none of them work great, because if one of them will work better than others, then we'll all be using it. And the point of the matter is that most organizations in many countries have actually developed their own guidelines. But I can tell you one thing, they've all basically tried to emulate what the ASA did back in 1993. And the ASA happens to be the first one that created the guidelines themselves. Now, this is the version that was published in 2017, and this is basically the most important algorithm that you actually seen. It was so important that we used to have it glued or basically stapled into our anesthesia machines and carts that we had in the room. Having said that, it's something that requires a little bit more attention, because if you were to ask me one description of what I think about the algorithm itself, is that it's a little bit of information overload. And specifically, not when you're studying it, not when I'm going to basically dissect it and put it into pieces, is when you're basically having some difficulty or a difficult case or a patient or something. It's very easy to get lost and you lose time because it's not so easy to navigate. But nonetheless, this is basically the newer algorithm. This is basically the version that was published in 2023. And this is kind of a little bit of the same algorithm, but number one in color. And I know that people that created it, they've actually put a lot of effort into it, and it's a little bit on steroids. Basically, this is the three main pieces. There's a lot more that you have to download and read it, because there's now also the added pediatric version, which is a little bit different. But we're going to be speaking for practical purposes of the adult version, which is basically divided into these three main pieces or of chunks of the algorithm itself. In fact, I like to call it the kind of, to put a metaphor, green light or basically a traffic light type of thing. Because the first thing that you have to remember is that every time, and I want you to read about this and study it, we're not going to get into depth, but the whole point that I want to make here is the fact that every time we face a patient, we have to encounter some kind of either anatomical, physiological, or case challenges that we need to basically navigate. And you have to make decisions. But basically, this first stage is when you decide what is the best conduct, what is the best thing that you can do for your patient, what will be more likely to lead this patient to have a successful airway management. So you need to answer a lot of questions. Does the patient have a risk for aspiration? Does the patient have anatomical concerns or physiological concerns, or a combination, therefore, that perhaps may lead you that instead of administering anesthetics and muscle relaxants, that perhaps the best approach is to do the patient awake. And that's the first question that you need to answer, and that's the first question that we answer ourselves. If we take the awake route, that's actually great. Very hard to kill somebody with that you intubate awake. But that's something that we normally do not do routinely. Unfortunately, we should be doing much more awake intubations, but we always find a reason why not to do it. Whether that's time pressure or the patient is intoxicated, you name it. And unfortunately, that's one of the drawbacks, and that's where we get into this red light stage, which happens to be when we anesthetize the patient and get into a jam because our plan A did not work. I want you to read about this, and what they're trying to do is what is the best conduct to do. So one of the first things, believe it or not, when you compare 1993 with 2003, is the fact that we now call for help early. The other thing is that we're trying to limit is the number of attempts that we do, specifically attempts at intubation. We've known for over 40 years that the greater the number of attempts at intubation, the less likelihood of successful management and more chances of adverse events. So we're trying to limit the harm that we actually do. And what we're trying to do is to also think about at one point we're going to declare failure, and we're going to say, no longer can I manage this airway basically with semi-invasive with intubation, and I might need to do a surgical or invasive approach, what we call now frontal neck access, or FONA. So that's in essence what the algorithm is like. So it's green light, yellow light, red light. Most of the time we get into trouble with the red light, and that's where we be spending the most amount of time. And that's something that you need to focus on and kind of develop your own plan. Now, there are others, and you can see here, for example, in this slide, the Canadian version and the Difficult Airway Guidelines, which is the Great Britain version of their guidelines. They're a little bit simplified compared to the ASA. We have to understand they came afterwards, and they've actually looked at some of the shortcomings of the ASA algorithm, so they've actually streamlined it. I'm particularly fond of the way the British do theirs, because the British see divided into structure: plan A, plan B, plan C, and I like to think that way, specifically when I'm pressed for time or I'm nervous or things get hectic. I'm more kind of a structured type of approach. The other thing that they do very well is that at each stage there's only two potential solutions: either you succeed or you failed, and if you do, then it takes you to a different place, which I think is very important. The American version is still too convoluted, in my opinion, and that's something that needs to be worked up. It doesn't really matter. The whole point is basically that plan A, B, and C, which I think is very important. If you think about that, then you'll be able to navigate it. And of course, you're saying I'm simplifying it, and I need to add the frontal neck access or the surgical option. And you're absolutely correct. The whole point is, if we divide it into that, then chances are that if you encounter difficulty with one of the modalities, then you may jump to the next one and the next one and the next one. And chances are that you're going to be able to navigate things adequately and promptly and opportunely. I think the best kind of teaching mental model is the ones that was created in Australia. It's called the vortex approach, and it's been the reason why you see those people there is because it's been adopted by many people, because it's the best metaphor that we can actually find. It looks at the airway as a vortex, and what it does is basically that's the vortex look from above, and this is the vortex look from the side. And what you do is you basically start going from one modality to the next one, limiting the number of attempts that you make at each one. And at some point, if you have failed in all three of them, all three modalities, which is face mask ventilation, supraglottic airway management, and laryngoscopy and intubation, then you have to declare failure and you have to provide surgical access to the airway. That's important because it's simplified. It's the same thing that the ASA has done, but it's a very simplified method. And guess what? When we are in a jam, we are not robots, and therefore your performance is not going to be great. So it actually really helps you to do that. Because at the end of the day, as I already alluded to, our goal here is to have the patient go back to his family, our patient, whether, like I told you, a baby or something like that. And I think that the most important contribution that the ASA has done has been basically that structure and management of Airway Guidelines. And you're going to be spending a whole lot of time with them. I recommend that you look at the algorithm, look at the pediatric and adult one, and try to think in your mind, okay, so if I encounter a problem, I'm going to basically do this, that, or the other. Because if you have a plan ahead of time, then chances are you're going to execute it, and therefore that's going to lead you to successful management. So thank you very much for your attention, and I look forward for our next lecture. Bye-bye.